part of the California Institute for Mental Health AB 109 Public Safety Realignment webinar series. Today's webinar will be on promoting recovery through forensic peer support. This webinar is designed to provide an overview of the evidence supporting forensic peer specialists in reentry services and supports for persons with histories of mental illness and criminal justice involvement. After today's presentation, participants will be able to identify the evidence supporting the use of forensic peer specialists in reentry services, describe core principles, direct care roles, strategies, and challenges of using forensic peer specialists in reentry services and supports, and discuss how citizenship and a sense of community belonging facilitate recovery among persons with mental illness who are formerly incarcerated. It is my pleasure to introduce to you our three presenters for today's webinar, Dr. Michael Rowe, Dr. Chyrell Bellamy, and Ms. Kimberly Guy. Michael Rowe is Associate Professor of Psychiatry and Co-Director of the Program for Recovery and Community Health, Yale University School of Medicine, Department of Psychiatry, and Connecticut Mental Health Center, as well as the Principal Investigator of the Connecticut Mental Health Center's Citizens Collaborative. Dr. Rowe's research includes citizenship as an applied theoretical framework to support the social inclusion of people with mental illnesses, including those with criminal justice histories, peers as staff and researchers, and mental health outreach, behavioral health systems of care for people who are homeless. He has studied patient-physician relationships in critical and high technology care and has developed training on forensic peer support and integration of culturally appropriate mental health care. He has authored over 150 articles, book chapters, and other works, and is the author and editor of 6 books, including Crossing the Border, Encounters Between Homeless People and Outreach Workers, Classics of Community Psychiatry, 50 Years of Mental Health Outside the Hospital, and the forthcoming Citizenship and Mental Health. Also with us today is Chyrell Bellamy. She is an assistant professor for Yale University School of Medicine Department of Psychiatry's Program for Recovery and Community Health, or PRCH, and the Director of Peer Services and Research. She has experience in research interventions for people with mental illness, co-occurring disorders, substance abuse, and HIV, specifically focused on the impact of sociocultural experiences in prevention and recovery. In her capacity as Director of Peer Services and Research, she provides instruction on peer curricula development and training based on her research and practice experiences with peer employees since 1993. And also with us today is Kimberly Guy. Ms. Guy is a supervisor, trainer, and engagement specialist with the Program for Recovery and Community Health at Yale University School of Medicine. Ms. Guy has worked much of her life as a nurse's aide until beginning work as a recovery mentor and leader in the recovery movement, sharing her personal story of hope and recovery from trauma, addiction, and mental health challenges. Ms. Guy has presented across the state of Connecticut and nationwide on topics including peer support and person-centered approaches to treatment and care for people with addictions, mental illness, and incarceration history. So it is a pleasure and real privilege to have all three of our presenters here with us today. And at this time, I will turn it over to Dr. Michael Rowe and our other presenters for their presentation on promoting recovery through forensic peer support. Dr. Rowe?
Hi, this is Michael Rowe. Thanks for joining us for this and for your interest in forensic peer support. And we're happy to be joining you, and we're going to pretend for a couple of hours that we're out there in sunny California with 70-degree weather as opposed to whatever it is now, 10, 20 degrees outside, and snow melting, but more coming. So also wanted to let you know that we will be switching back and forth a bit. The first time we switch, we will give our names, and then after that, we'll pretty much know the voices, and we'll just switch back and forth. But before going Before starting the presentation proper, I just wanted to say a few things about our program and a little bit more about what we do. PERCH, as we call ourselves, Program for Recovery and Community Health, is a research, mainly intervention research and training program, among other things we do, with an overarching framework of recovery and citizenship. Peers as direct care workers and recovery and citizenship go together very well, we think. And each of us has been involved in this work for quite a while. Dr. Bellamy is Director of Peer Services and Research for PERCH, and she's developed many peer-delivered programs across the country and internationally with nonprofit agencies, regionally, nationally, internationally. She's developed peer programs at our local mental health center, at a local federally qualified community health center, at hospitals, and for the Connecticut Department of Mental Health and Addiction Services and its local mental health authorities. Kimberly Guy is a peer supervisor with our program. She's worked with Dr. Bellamy on trainings on forensic peer support, organizational cultural competence for addiction treatment agencies, peer recovery employment services, peer staff in person-centered planning in the behavioral health workforce, and development of a citizenship training model and manual. And she has also authored a guidebook on the pardons process and has taken the lead in Connecticut from the peer perspective on advocating for pardons process reform, especially for the peer behavioral health workforce. I started with peer work in the mid-1990s with mental health outreach work, and my citizenship work, which you'll be hearing about, came directly out of that work, and peers have been a central part of that work, the citizenship work that's been going on for about 15 plus years now. I also was the principal investigator for a study of peer engagement specialists integrated on community-based mental health treatment teams as a prospective alternative to outpatient commitment, since Connecticut does not have an outpatient commitment law. And I'll touch on some of these findings in a bit. So you've heard the presentation outline, but just quickly to go over it. We'll be talking about core principles of recovery and peer-delivered reentry services. Is it turning? Seem to be having a little trouble with the cursor here. Thank you for your patience.
Okay, go ahead and try to advance those slides one more time by hitting the arrow key.
Sorry about this, folks.
There we go. We can see them.
We see the slides. We don't see them advancing it. Okay. Okay, so here we are at the presentation outline. We'll be talking about core principles of recovery and of peer-delivered reentry services, peer work also in general. We'll be talking a bit about the evidence that supports the use of peers in mental health settings and in forensic settings. We'll actually be talking mostly about our research, not because it's the only research or necessarily the best research, but because it fits, we think, with the presentation today and ties in with the points that we'll be making. We'll be talking about both the direct care roles for forensic peer specialists, and we'll also be talking about organizational strategies and challenges, since that's part of bringing peers into the work with people coming re-entering from criminal justice charges, is integrating peers into your organization. And we'll also be talking about the citizenship model for promoting recovery and reentry, and the peer mentors' involvement with that work, forensic peer mentors. So, still having a little trouble advancing that. Okay, all right. No, we're.
Okay, Dr. Rose. So we see the slides. There is a lag in time, a delay in the slides transitioning.
I wonder if, can you take over from there? I'm wondering if that, because we're, okay. All right, so here's what we expect and hope that you'll learn today, what you'll be able to do. You'll be able to identify some of the evidence supporting the use of forensic peer specialists in reentry services. You'll also be able to talk about the principles, ideals behind this work, about direct care roles of peers, forensic peers, and also about strategies and challenges of using forensic peer specialists in services and support, and integrating forensic peer specialists into your agency. And we'll also talk about citizenship and how citizenship and a sense of belonging that's matched by others' recognition of your belonging facilitates recovery for people with mental illnesses who have criminal justice charges and are coming re-entering the community. So a couple of definitions here, core principles and definitions. A peer staff person is a person in recovery who offers services and supports to other people in recovery. That's a definition from Larry Davidson with our program. I want to note that we're going to be talking today about people who disclose their peer status. You can be a peer who provides case management and not disclose that. We're talking about peers who do disclose and draw on their experience as peers in their work. So peer support is a way of giving and receiving help, and it's based on values of respect, cooperation and agreement, and a sort of partnership between the peer mentor, the peer specialist, and the person receiving the services. And reentry support is built on those same values. Okay, so what is forensic peer support? So forensic peer support involves using peer specialists who have histories of mental illness, may also have histories of co-occurring substance use, and in most cases usually also have criminal justice histories, working in criminal justice settings or working with people as they're re-entering the community. So being a forensic peer specialist means and involves understanding the culture of the impact of being incarcerated on people's behavior from that perspective yourself. It also involves a recognition that many people coming back into the community with mental illnesses, with incarceration histories, are suffering from trauma and post-traumatic stress disorder, and understanding that this group is critical.
This is Chyrell Bellamy. The overarching principles are what drives the way we think about the work of forensic peer support. These 5 philosophies, so to speak, we believe have helped us both in terms of organizational implementation of forensic peer support, as well as in the training and preparation of staff. And those are recovery, person-centered planning, citizenship and the 5 R's, intentional peer support, and trauma-informed care. I will briefly go through each, as I believe many of you are probably familiar with these approaches. So the first is recovery. As you can see in the underlined sections, those are the points that are the most salient to recovery. It's a person's ability to achieve a meaningful life and a positive sense of belonging in their community.
This is Kimberly Guy. Person-centered. Person-centered approach is a way that we use in giving a person their choice back. A part of their recovery is like putting them back in the driver's seat. in so many ways after being incarcerated, the choice is taken away. So being person-centered is the core of anybody receiving services. It's their voice. It's their voices. The person's in the middle. People want things in life that everyone else has. Building positively in the community, having the same rights as others, gainful employment, staying clean, having a healthy relationship, keeping out of prison, starting over again, and sometimes that means starting over again and again.
So I want to say a bit about citizenship. First, let me start with this. Why are we talking about citizenship when we already have recovery? One way to think about this is that citizenship brings recovery into the community and brings the community to recovery. And we talked about the 5 R's of citizenship as the rights, responsibilities, roles, meaning valued roles, resources such as housing, vehicle, income, other resources, and relationships, one-on-one relationships, social networks, groups, and so forth, that are part of being a full member in the community. And without having those 5 R's, we argue, you can't truly have a sense of belonging in the community. And that belonging in the community that you strive for also has to be matched by others' recognition of you as a member of the community and that you belong. Citizenship started, had a couple of different beginnings. One of them was in mental health outreach when we found that we could do everything and go out and find people with mental illnesses who are homeless and provide a lot of services to them, provide treatment to them or get them into treatment or refer them for substance use treatment, help them get SSI or whatever, or other income through work, and we could get people into housing. And it was at that point that we found that there was a problem. The problem was that we couldn't help people become neighbors, community members, and citizens, and they often did not feel like a neighbor, community member, and citizen. The second beginning of citizenship is more directly tied to what we're talking about today, and it came out of jail diversion. One of our colleagues, Madeline Bernowski, who was interested in the citizenship work we were beginning to do, said, jail diversion is great. It involves taking people with mental illnesses who would get caught up in the criminal justice system and bringing them into the mental health system, and that's a good thing. But what we're doing, in another sense, is we're moving people from one system to another, and we're not really doing anything about helping people make a life in the community. And after all, that's where community mental health started, was the idea of not only can you get effective treatment in the community, but you can have a life in the community. We've had several different interventions with the citizenship framework. We've had a community level intervention. We've had an individual level intervention, which is the one that is most relevant to what we'll be talking about today. That's the Citizens Project. We've developed a measure of citizenship, and we are now bringing citizenship-oriented care to a large mental health center.
Intentional peer support is the work of Sherry Mead and Chris Hansen. IPS is a way of being and relating differently. It moves us away from this notion of helping, because often we've helped based on ways that we've been helped in the past. And this may not always produce the best results. IPS is about learning about the person and incorporating the 4 tasks. The 4 tasks are connection versus disconnection and reconnection, worldview, and contextual factors, which is really important to our work, because understanding the context and the situation by which we've all come from is really important to learning about individuals, but also understanding how that might influence the relationship as a whole. mutuality, and mutuality in the sense of peer support is, as we say, if it's not working for both of us, then it's not working. So how can both individuals contribute something to the relationship that's different? And moving towards. And moving towards is about creating a new way of thinking about a situation. Mead and Hansen refer to it as, holding to truth, but creating a different conversation that moves us toward a different way of being. There's more information at the web link below on intentionalpeersupport.org.
Okay, just to quickly go through some of the evidence. As I said, we're going to be talking about the work that we've done here in New Haven and in Connecticut. We'll start with the ENGAGE studies, two different studies. The first in 1992, 1993. This is our colleague Larry Davidson. It was a small randomized controlled trial of people who were being frequently hospitalized, and this was the real problem at the time. What can we do to decrease these hospitalizations of these folks? And some qualitative work was done and found that, well, that's one of the places where people felt welcomed. So that leads to the question of how can we provide a welcoming atmosphere for people in the community, which led to the ENGAGE peer support group, which was tested against usual care, and findings were fewer readmissions and hospital days and increased use of outpatient services and self-help groups among those who were receiving the ENGAGE intervention compared to those receiving usual care. And the follow-up study, NIMH study, to this had different findings, but those was also a randomized controlled trial. Also had, in this study, found greater increase in social functioning, greater understanding and of the importance of alcohol treatment, reductions in problem drinking, more time spent in care than in the control group. In 2000 to 2002, the legislature in the state of Connecticut was considering an outpatient law, and the advocates in Connecticut went to the legislature and said, let us try something different. Let us try to reach the folk who would be subject to outpatient commitment law if such a law were passed. Let us try to engage those folks. And the way that they proposed to engage folks was peer engagement specialists who would be linked to community-based treatment teams. We provided the training for this programming. We evaluated the program. So this was people who were unengaged in treatment and who had histories of either violence or the threat of violence against themselves or others, and who would be subject to outpatient commitment if it were passed in Connecticut. And comparing this care with care they received from peer engagement specialists to regular case management care. So what did we find? We found that people receiving the peer engagement specialist care felt more positive regard from their peer specialists than did those in the usual care from their case managers. That was the first thing. The other findings had to do with motivation for treatment. People receiving the peer engagement specialist intervention were more motivated for treatment, for other care, than those receiving usual care. And as I said earlier, the lack of engagement in care was the issue that would put people under outpatient commitment if such a law were passed. Peer engagement, interestingly, also, in addition to clients receiving the peer engagement specialist intervention, in addition to feeling more positive regard from their peer engagement specialists, also responded more positively to negative regard from their peer specialists in terms of motivation for treatment. So you could then did those who were receiving a negative regard from their case managers. The point here being that in this case it appears that tough love from the peers worked where it didn't work from case managers. The Citizens Project. The Citizens Project has 3 different main components: a course, series of classes, daily role projects, and wraparound peer mentor support for people with criminal justice histories and mental illness. And here's what we found from that study. The citizenship participants, and this is compared to usual care, had decreased drug and alcohol use. They had increased quality of life. For those who were working, which was about 40% of folks across both conditions, those who were working had more satisfaction with work if they were in the citizenship intervention. Interestingly, both groups had decreased arrests. So that may say something about the importance of simply being in treatment. A couple of qualitative findings. One is that we found that the citizenship students, and they are called students, not participants, not clients, were able to build a strong and supportive community, a community within a larger community, and one that encouraged people to move out to the larger community. We also learned that being a student was a valued role in and of itself. Learning and knowledge were major themes. Just a note on some current work and ongoing work. We've been working over the past couple of years with an organization called PeerStar. They hire peers to go into the jails and prisons in Pennsylvania. We're working with them. We have provided training to them on forensic peer support and on replication of the Citizens Project. We have developed a manual of the Citizens Project. Dr. Bellamy, Kimberly Guy, and Patty Benedict, the director of the Citizens Project. And we are also, coming up in May, trying to now tie forensic peer work with innovations in forensic psychiatry at large, with conferences coming up in Connecticut and in Montreal.
So how can peer specialists assist in roles as forensic peer support specialists? For these next two slides, at the top of each slide are common issues that have been discussed in literature as well based on our research and practical experiences. So in terms of social isolation, the ways in which peers can assist is by enhancing their social networks through role modeling and facilitating peer support activities. And role modeling always gets a little, tricky because it places a huge responsibility on peers. So we like to refer to it as role modeling one model and one particular way of doing. In terms of disconnection with ongoing outpatient treatment, we know that this is certainly a concern. Peer specialists assist in engaging clients to services and as well as to other resources in the community and making treatment more relevant through collaboration. Collaboration with the client as well as with service providers and family members. In terms of powerlessness, demoralization regarding, particularly regarding mental illness as well as regarding the history of incarceration, activates clients, teaching coping and street smarts, many of which individuals already have. And one thing that we really try to bring home in terms of forensic peer support in particular is that this is a process of peers learning from each other, because often the individuals that we're working with have a lot to offer us in terms of learning about resources and what's available in the community, and providing hope and through role modeling that assist in, particularly in terms of demoralization. In terms of our overburdened and under-resourced providers and system, forensic peer supporters certainly supplement the existing treatment services. And we say the same thing in terms of fragmented services, that by providing, and I should have put case management in quotes, because peer supporters, in essence, do not, manage cases, but instead provide support to individuals who have similar life experiences. But they also assist in navigating the system and increasing access to services as well as retention to those services. And in terms of a systemic lack of emphasis on recovery and the recovery approach, peer supporters can emphasize recovery, can serve as a liaison between providers as well as the client. And we found that this is often useful, particularly to clinicians, when peers are able to break down what are some of the experiences that the individual might be having to the clinician and provide a more context to what some of the issues and concerns might be. Some of the things that they might be leaving at the door and may not be willing or know to even bring up with their clinician. Peer supporters also challenge stigma. Because of their own experiences with stigma, it's important that they feel that they can address and advocate for the individual so that they can get the services and the resources that they need. And peer supporters serve in emphasizing community inclusion over symptom stabilization. And by that we mean, particularly in work around recovery, that we can't just wait for people to, quote unquote, be stabilized from their symptoms before we start talking about how to get them back into the community, but figuring out ways to capitalize off of their strengths and move them towards community inclusion in a way that's person-centered. So what are some gifts that peers can offer? The installation of hope. Having been there, and I actually identify as a person in recovery, and having been there and can talk about my own experiences is one way of modeling what recovery is for me, and while it may not be the same experience for someone else, it certainly gives them a sense on ways in which I went about doing it myself. Peers offer mentoring, engagement, street smarts in navigating the system, or simply just how to get by and live day-to-day life. Because we know that the experiences of poverty and discrimination and unstable housing are real concerns. And as people who have been there and struggle with some of those circumstances, it's often good to at least talk to someone about those experiences, but it's even better to talk to someone who knows how to navigate those services for themselves. Community networking and connecting. And this is something that, particularly for individuals with a history of mental illness, who have experienced this sense of disconnection from society, being able to connect and reconnect with family members as well as with the community at large is really important in order for us to feel a sense of belonging. And then there's this concept that we talk about, Lift as We Climb, which was the model of the National Association of Colored Women coined in the 1920s. And Lift as We Climb is simply that as we are all climbing this ladder and moving towards the things that we want in life, that instead of pushing people back down, we lend a hand and we climb the ladder together so that we are truly, and so that people truly believe that we are in this together. And I think that that sense of individuals believing that we're in this together means a lot.
So why do we need forensic peer support? Well, our job is to persuade you that forensic peer support works and that you need forensic peer support. On this slide, I'm going to tell you and summarize what you probably already know. There are a lot of people in this country going into prisons. There are a lot of people with mental illness going into prison. And there are a lot of people with mental illnesses coming out of prison. And in coming out of prison, in re-entering their communities, they face the stigma of being, and discrimination of being ex-offenders, along with the discrimination and stigma associated with having mental illnesses. And therefore, there's a lot of recycling back and forth, and people need a lot of support.
This next slide is a term called post-incarceration syndrome, coined by Gorski. Now, this is not in your DSM. However, we find it a useful concept for understanding what might be some of the experiences for people that have been incarcerated. The experiences of having been locked up, having been institutionalized. So the first one is institutionalized personality traits. From deprivations of incarceration, this chronic state of learned helplessness in face of prison authorities, as well as in the mental health system. And these are behaviors adapted to deal with other prisoners, to deal with the system as a whole. The second one is post-traumatic stress disorder, which is in the DSM, from both pre-incarceration trauma as well as from trauma experienced within the institution. Unfortunately, you know, for many people with mental illness, many, as you say, some of us never really had services prior to getting locked up in the first place, and often did not even realize that we had mental health symptoms until faced, you know, with experiences in the incarceration system. So it's really important that we understand that traumatic experiences have been something that individuals have been dealing with for a long time, that they may have not have even realized that they've had these experiences. This third one, antisocial personality traits, I find really interesting because we throw around the term often of antisocial when classifying prisoners in the system, and without also recognizing that antisocial personality traits are something that we've sort of adapted to. These were developed as coping response to the institutional abuse and from behavioral adaptation within the prison environment. For instance, one individual talked about just in terms of not wanting to be around other people once he got out of the prison and coming off as, you know, sort of standoffish, but had to adapt to that behavior when he was in the prison environment, just because, so that he could stay clean and stay out of trouble. The other experience that someone talked about was even something as simple as learning how to open the door for themselves again, because they were so used to having the guards and, you know, other prison personnel open doors for them. The fourth one is social sensory deprivation syndrome, caused by prolonged exposure to solitary confinement or environment, being locked up. And we can probably all sort of get a sense of what that might be like, just being confined and being in a cell, whether or not that's, and that's not even solitary confinement, that could even be within the walls of a cell with a whole bunch of people in tight quarters, and what that might be like to someone having that experience for years and years in and years out. So these post-incarceration syndrome coexist with the other present, like, diagnosis that an individual might have, whether that's substance abuse or other affective or personality disorders. Jack Maruna has come up with 3 ways of describing sort of the process of the criminal justice system, and he calls these criminal justice narratives. And the first one is control-based. And here is where we see people are seen as risky until proven guilty. So our system is sort of based on this, this need to control individuals once they are released from the prison. So we can think about that in terms of probation and parole and other sanctions that have been placed on individuals. The next one is support and needs-based. And this follows the logic of if people can get their needs met, they're less likely to recidivate. That's definitely true. What tends to happen, according to Maruna, is that it also adds a bit of control to this, because the story goes, if I don't follow through on what it is my provider is asking me to do, then sanctions are then put in place. So again, it goes back to this way of controlling. And Maruna is really urging us to move toward a more strengths-based restorative approach. And that's where we ask not what the deficits are, but what are positive contributions a person can make. What are their strengths? And it's not like diminishing the fact that, you know, parole and probation has to happen, but it's really focusing on how can we take the best from the individuals and use those strengths and capitalize on what they can do instead of what they can't do. Because obviously many of them have been told so long about what they can't do, so us furthering that message may not be the best approach. And I'm just going to read this quote by Dr. Taxman. The nature of prisons and prisonization dilutes the offender's sense of responsibility. Part of successful reentry lies in ensuring that the offender's role is defined as a critical component of the reentry process. In fact, it is important for reentry to occur in a manner that empowers the offender to be a productive citizen contributing to the community. So this is why peer support is needed.
So we train the basic, our training overview, the basics of the justice criminal reentry, the overview of recovery and peer support, PCP and IPS, developing empathy and self-awareness. We teach using people in recovery with mental health and co-occurring substance abuse concerns and experiences of incarceration. Day 3, we work with people in recovery with mental health concerns and experiences of incarceration. And then at the end of day 3 is a brief exam.
So continuing with the components of the forensic peer support training, as I talked about earlier, those 5 overarching principles, those are critical to the work that we do in terms of the forensic peer support training. And the other features are listening differently, connection, reconnection, and really trying to come from a
a trauma-informed care perspective, because recognizing, again, those experiences of trauma. In particular,
working with people with incarceration, it has the overview issue of probation and parole, where people are going to live, the interaction with police once out of incarceration, understanding the impact of sex, gender issues, employment, dealing with having the 3 strikes against you, gaps in work history, issues of loss, working with people and returning into relationships. These are the components in which some of the training surrounds. So, support, and getting back, support with the 5 R's helps people in recovery find humor in everyday situations, explores what they really like to do for fun and relaxation, because a lot of people forget about fun and that how much a part of fun is in recovery. Together, research low or no cost of community activities, work with people in recovery on developing fun and relaxation plans.
I want to comment on this business of having fun. It may seem trivial. When I started work, I ran the homeless outreach team for the Connecticut Mental Health Center back in the 90s, and I was trying to learn about this work. And I had a colleague who had been homeless himself, and he acted as a sort of guide to me. And we went out on the street, and he would show me places where people who were homeless were gathering, and he would introduce me to people and kind of explain what it was like being homeless. And the very first day that we went out, and one of the very first things he said to me is, homeless people don't know how to have fun. And that has stuck with me ever since. And I don't think that just applies to people who are homeless. I think it applies to people who are marginalized, who are under a great deal of stress, who are trying to survive from day to day and trying to make some progress. And fun seems like a little thing, but being able to have fun really is a big thing. And I think we need to keep that in mind as we're working with people with some real difficult challenges they're facing. So the Citizenship Project, basically, so we were able to get some funding to work with people with mental illnesses and criminal justice histories. And these criminal justice histories ranged from petty offenses up to major offenses. We were not just dealing with people who walked up to someone at the bus station and started lecturing them in their faces, trying to make contact with their fellow citizens, but doing it inappropriately. That happened too, but we were also dealing with people with felonies. And so we thought, okay, we've got 5 R's. How are we going to take this idea of rights, responsibilities, roles, resources, and relationships and put it into some kind of an intervention? And basically, we did the best we could. And we came up with this notion of a group component that would include classes and valued role projects, and I'll say more about each and about public speaking and what's up. Kim will talk about what's up in a moment. And we have wraparound peer mentor support. And that wraparound is from the beginning to the end and beyond, including people who have graduated from the Citizens Project, or for those who are interested in continuing to get some peer support after this intense intervention and suddenly not having it. And that's individual peer mentor support, and it's also group support in the classes and the valued role projects. And then graduation at the end of the 6-month project, which takes place at City Hall. One of our recent graduates said, the last time I was in City Hall, I was in trouble. So the notion of graduating in City Hall and having the new mayor come and speak, as happened recently, is an important thing. This notion of rites of passage also comes from Shab Maroon by way of Dr. Bellamy, who really introduced this notion. And graduation is an obvious rite of passage, an important step in one's life. But we think of the entire Citizens Project as a sort of rite of passage from the non-citizenship of being incarcerated, of having being very marginalized society by mental illness and criminal justice charges, toward becoming a full citizen. So our goals, you'll see the 5 R's in here. Understanding rights, understanding one's responsibilities in relation to the criminal justice system, the mental health system, the community, identifying ways to address these rights and responsibilities, looking at one's current social roles, identifying ways in which they have been helpful or problematic and how people might change them. Learning. I often say to people, citizenship is not a skills building project. And I'm exaggerating a little bit because I want to emphasize the fact that we're talking about building citizenship. But in fact, it's both skills building and citizenship building in the larger, more abstract sense, but both need to happen. Helping people to develop supportive relationships through the Citizens Project, through this mini community, this small community of the Citizens Project, and then moving out from there, and getting support from your fellow students to reconnect with family members where those connections have been severed, to make new and positive relationships and develop support and supportive networks.
Some of the classes are relationship building, where it teaches you about family dynamics and dealing with issues such as Department of Children and Family Services, how to relate with court issues, communication skills, negotiating the criminal justice system, housing options and issues, vocational development, education development, spirituality, health and alternatives, HIV prevention, advocacy, and public speaking. And a lot of these classes they're written up as prior, so that the students get involved with classes, because we find that in these classes they have a lot of skills and things that they bring to the class themselves, and things that they picked up along their journey, so that they become a part of the class and on presentation day. And one of the words that was said, I learned how to advocate for myself. It gave me the courage to go back to school, and that's from one of the students. We have the group that we call What's Up. What's Up is created by the students. It's a way of sharing their personal challenge and day-to-day rewards, and also it's a way of receiving feedback and maybe sometimes critical feedback from your fellow peers. And it's like you come in with a problem and you might have 13 feedback, so you have a choice of different options, a way of looking at things, and sometimes it's hard to accept feedback from other people, but when you know that they've been through the same thing that you have, it's kind of easier to take. And also, one thing I like to say that game recognized game. So sometimes we know when we're being bullshitting each other. So I like to say I use that game recognizes game. So that's the way of saying what's up. I learned how to talk to people, listen better, and deal with my problems. That's one of the students saying. Public speaking.
So I just want to add a couple of things on the What's Up. one thing about what's up, there are a set of rules, and I'm just going to mention one because it's kind of striking to me. One of the rules is the individual gives their what's up. This is what's happening with me. And important to note that part of the idea is this is not just about how I'm doing with my drug use. This is not just how I'm doing with my mental illness. This is not just how I like my clinician or don't like my probation officer. This is what's happening in my life, and that's really encouraged by the group. One of the rules of what's up is you give your what's up, and then you're given feedback by the rest of the group. It could be a couple of different people give you feedback, or more or less, but you get some feedback from the group, and you cannot respond to the feedback. Now, why would that be? Well, the reason that came about is that if you're in many situations, people are in kind of a back and forth with each other, and oftentimes when someone is giving you some feedback, what are you thinking? You're thinking about how you're going to respond to them. The thing with what's up is, okay, you're going to have to sit with this and think about it. And people do talk about this, how they've gone home and thought about what was said to them, and it's had more of an impact on them. So public speaking. So what's this with all of the speaking? What's up in public speaking? We, in the original study of the Citizens Project, we had a 4-month intervention. And in that 4-month intervention, about 10 weeks of it was the classes, and there were 2 public speaking classes. And then we moved to a 6-month intervention, and Patty Benedict, the director of the project, shifted to 4 public speeches. And at one point I said, what's the deal with all of these public speeches? I mean, we're not training people to be public speakers. And I didn't quite get it. But as I thought about it and I looked at the topics of the public speeches, what are they? They're people talking about themselves. So people have to come up with 5-minute speeches, which they then give to the class and then are recorded. They talk about themselves. That's the first speech. The second speech is talking about their community as they understand it, as they see it, what their community is for them. The third is talking about about goals and how they plan to attain them. And you may notice that goals is repeated there, and those goals. That is not a mistake. That is an icebreaker as we move into discussion. So the fourth one is, it was an error, sorry. The fourth one is what people have learned from their fellow students. So think about what happens when you give a speech. In order to give a speech, you have to think about what you're going to talk about. You have to think about your time limit. You have to practice it. You have to write it. You have to then give it in front of others. You have to then take feedback from others, and you have to presumably learn from that feedback in order to do better the next time. And think about it in relation to job interviews and for employment, for housing, and think about the topics, talking about oneself, about one's community, and about the goals. And I think this public speaking makes a lot more sense. That said, Dr. Bellamy and Kimberly have pointed out that if there's anything that is really unique about the Citizens Project, more than anything else, it's the valued role projects. So valued role projects are individual projects or group projects, or sometimes a combination of the two. They are the last part of the project before graduation, the last couple of months of what is now a 6-month project. People have to think about what would be something that draws on their interests, their strengths, that would be a socially valued role and that would contribute to the community. What are they doing by doing that? Well, they're educating people in the community, both in terms of the topic itself and in terms of the fact that people with mental illnesses and criminal justice histories who are reentering the community can, in fact, take on valued social roles, and demonstrating that to the community and to themselves. So I said that these can be individual valued role projects or group valued role projects. I'm going to just tell you about a couple of my favorites. One of the early group valued role projects had to do with training police cadets these are people who are training to be police officers, going to the academy, several of the students, and teaching the cadets what it's like to be homeless, to have a mental illness, maybe just having been released from incarceration, and to be approached on the street as you're homeless, living on the street, by not just one police officer, but usually a couple. Scary thing. So the information for the police cadets, these soon-to-be full-fledged police officers, was helpful, I think. And consider how the roles have been turned around from being the person who is approached as probably problematic. Why is that person out on the street? Must be homeless. Maybe there's other things going on. Let's go check it out. There's a negative aura to that whole approach, no matter how it goes, and it's scary. And suddenly the tables are turned, and the people who formerly would be approached on the street are now teaching these emerging police officers, and hopefully that helps them in their work out on the street. So an individual valued role project, and this is another one of my favorites. This was a gentleman with a mental illness who did not have a history of substance use, and he had no understanding and no patience with people who did, and there were lots of people in the class who had histories of alcohol or other drug use. He just couldn't understand it. Why can't you just stop? If you want to be a full citizen, if you're looking to rejoin your community and all of these other things, why can't you just stop? Someone in the group suggested to him that perhaps he needed to learn something about empathy, and he said, oh, "Okay, I'll do that." And so he went online. He did some reading. He found out what empathy was. He came back and started to talk about it in his What's Up. At the beginning of one of the classes, and people said to him, "Oh, that's interesting. Perhaps you could teach a class on empathy." And he said, "Okay, let me prepare for that." And he came back and he taught a class on empathy. And at the end of the class on empathy, his fellow students suggested to him, "Okay, now maybe you can try practicing empathy." And he said, "Well, okay, I'll try that too." And he's still learning, but he is practicing. So the Valued Role projects also, we think, can enhance students' community connections, with other people out in the community.
Having lived experience with mental illness, peers on the Citizen Project. Having this experience with mental illness and addiction and recovery in the criminal system provides support, and they share their knowledge and experience. Peers help students to empower themselves, helps to ensure positive and productive classroom and community experience.
So I won't spend much time with these. These are some of the comments that students make, and let me point out that middle one. We can laugh about stuff, and it makes me happy when I come here. Again, what I was talking about with this business of having fun. We think of the Citizens Project as both a supportive and a challenging atmosphere. And if you think about this notion of rites of passage, that's kind of what a rite of passage is about. It's a structured and supportive opportunity to be challenged toward where you hope to be going. And so we continue to learn from the students as we go along.
So what's in this for organizations? Some of the benefits are that peers can fill the identified service gaps. We know there's more to be done here. There are not enough providers, and even if there are, having individuals with expert knowledge based on their own personal experiences can certainly serve as an augmentation to some of the services that they're currently receiving. Peers provide expert knowledge across agencies as a whole, whether on organizations, committees, in the development of materials, communicating with other service providers, etc. Having folks that have been there as partners in a true sense provides a wealth of knowledge that we should all sort of take hold to, because I think that as we're able to learn from each other, peers learning from clinicians and clinicians learning from peers, we're going to be better off in terms of improving the overall services that we're providing to individuals with a history of mental illness and co-occurring issues who have experiences of incarceration. FPSs also influence agency culture and the overall recovery orientation. Now, I'm not saying that this is something that we should expect that peers can do alone, because the organization as a whole will certainly need to work on sort of, practicing recovery orientation so that there is a community by which the peer can do this work. What we have seen in this situation, which we'll probably talk about when we talk about some of the challenges, is that some of the peers have talked about microaggressions that they've experienced, sort of the slights, that feeling that other staff think that they're less than, that they're not qualified to do their work, etc. So having this overall sense of recovery orientation and citizenship orientation, I think, really serves as the base by which the organization can make sure to do at least as much as we can in terms of reducing some of those microaggressions that individuals will inevitably experience. Establishes a cohort of known talent for career development. And I think this is really important because as individuals are a lot of people who are returning from incarceration, a lot of people with a history of mental illness and substance use talk about giving back. And giving back is important to their recovery. And anything that we can do to develop ways in which they can do more of that, and then developing a career track and a leadership track by which they can then become leaders in the field, is going to be important to this work. Some key factors of implementation of forensic peer support, and these are not in order. So I don't really think there's any set order to any of this. So one of the first things I think is important, though, however, is to convene the stakeholders who are involved, and that's officials from jails and prisons, from the mental health system, from courts, probation, people in recovery, from community-based organizations, family groups, neighborhood stores, etc. All of those people and places that individuals have been involved with, and have these individuals at the table to figure out how to best develop what might work for your organization. I can't emphasize enough to gain organizational buy-in on principles of recovery and citizenship orientation. Often in terms of our consultation, we find that many organizations want to bring on not only forensic peer support specialists, but peer support specialists in general, but yet there hasn't even been a sense of all staff have been sort of even given a Recovery 101 orientation. And since there's often so much turnover within human services, figuring out a way to do this on an ongoing basis so that new staff are also getting the information. Training of all staff on a strengths-based, person-centered approach is going to be really important and to the work. And training, the hiring and training of peers and forensic peer support. So first of all, we know that there's a lot of issues here in terms of hiring individuals who have histories of incarceration. Some states have done better than others in terms of recognizing that individuals have histories of incarceration and working with them in terms of bringing them into their individual organizations, and as well as going into jails and prisons. But in situations where that's not possible, deciding on whether or not to have either a program that focuses on community support for peers who are with a history of incarceration who are not able to actually go into jails because of their criminal histories, so that they can still work with the individuals as they come out into the community. And some programs we know hire individuals that may not have histories of incarceration who can actually be the ones that go to jail, or people who have been expunged or pardoned from their histories of incarceration who can go into the jails and work with the individuals in a reentry initiative approximately 90 days before going back to the community, or a combination of the two. So for instance, the Pure Start program that we referenced, that's in those rural counties in Pennsylvania, they recently just started a citizenship group, which Michael just discussed, in Delaware County at prison. And so these are for individuals within 90 days of leaving the jail who will attend the citizen groups and have those classes which have been modified specifically based on what resources are available to them within a jail setting. Obviously, you know, the whole concept of valued role and some of the other activities that you might be able to do in the community might have to be modified if you're doing them in a jail setting. But a combination of the two is what we ideally would like to see happening, because, yeah, I mean, you can work with individuals who are in jail and work with them those 90 days while they're there, but, you know, we almost have to kind of be at the gate for them when they get out so that you can provide that support that they need in terms of transitioning and doing our best to work on some of those 5 R's so that we can at least have even just a small way of reducing some of the recidivism that has occurred just even recently, you know, within like moments of people even just getting released. So anything that we can do to make that transition more easier for folks as they're coming home from jails is going to be better for the individual.
So some of the criminal justice backgrounds are like one of the #1 factors of people of peers being hired in organizations. And to piggyback off of what Chyrell stated, that it's so hard when people are coming home and by the time that you get to work with them, the hopes and stuff has been tainted because the walls have already started coming up, so the hope has been started going down. So if we could get things going somewhere in that first period of them coming out of the gate or even before, it would be so much good, because that's the #1 challenge, creating a career of vocational path in within the system, because peers get hired, but there's no like kind of long-term positions and stuff. So it's like, you know, what comes next? It's like you're building people up and there's no kind of follow through or no next level step, like becoming supervisors or leaders within the field that they're working in. Supervision and administration and educative supportive things of furthering people careers, teaching them how to work around settings with microaggressions and different cultures and stuff, because a lot of people haven't had work experience. People who are have to deal with mental illness or incarceration hasn't had really work experience. So having issues of working around stress and setting limits and adjusting to working. Being able to have a salary that stands up to so that you can live on is very important. So them are some of the challenges.
And the last one, and we're just about done, is training. And training is vital to this work. I would say training and supervision are the two of the most important things. Training, initial and ongoing, and I say ongoing and ongoing and ongoing. There's this assumption that we develop these either 3-day trainings or, 10-day trainings for forensic peer supporters to go off and do this work, when we as social workers or psychologists or have gone to school for many years and still may not often need training to do the work that we do. So it's going to be really important that we find a way to continuously try to cultivate those new skills. And the other thing about training is also training individuals how to work with other staff, and particularly training case managers and peers how to work together. Because for lack of a better word, they are often at the quote-unquote low end in the organization, but yet they are the frontline providers. They do all the work and rarely get the support that they need in doing so. And it's really, so often what happens is they're pitted against each other instead of being cultivated as being a source of support to each other and figuring out how to work better together. So we really try to work on fostering relationships between the individuals who do all of the, the direct service work, so that they're working together and feel like they're in this together and not feel like it's us versus them, and reducing that as much as possible. And in terms of, and I can just say, in terms of supervision, in a lot of the consultation that Kim and I do, we're actually in the process of completing a supervision guidebook right now for supervising to peers. There has to be a balance of focusing on administrative, educational, as well as supportive supervision. We've heard people say things as they feel as if they're babysitting, or they feel as if they have to help people deal with their symptoms, or they feel like they're spending too much time on teaching people basic computer skills or training individuals. And we've also sort of adapted based on some work of Sherry Mead and Chris Hansen, as well as work that has been done, particularly in nursing and psychoanalysis, this whole concept of co-supervision and reflection, which is training peers on how to provide a sense of support and supervision to each other so that they can reflect on the work that they're doing. Because often as supervisors, just because, it's real, I mean, not having the time in the day to provide adequate supervision needs to be recognized. So co-supervision provides a way for staff, we say peer staff, but we've also done co-supervision for all staff who are learning new skills together so that they can learn and reflect on these skills and learn how to practice in a different way. So thank you.
And we're ready for your questions.
Thank you so much, Dr. Michael Rowe, Dr. Chyrell Bellamy, and Ms. Kimberly Guy for your presentation today. I really appreciate how informative that is. It's really encouraging to hear the evidence that is being accumulated to support the role of forensic peer specialists in reentry services that you've collected, and really appreciate your sharing really the nuts and bolts of how to implement it, because I think that's where, that's the tricky part, and for giving us a lot of real meaningful experience around how you implement it, and appreciate also how you articulated how you make it recovery oriented and person-centered and really positive and uplifting for the folks who participate in the program. So anyway, thank you very much. And at this time, I will open it up to questions from the audience. And just a little reminder about how to ask your question. What we'd like you to do is to type your question in the questions box, excuse me, and then we will see your question and we could read it out loud and have the presenters respond to it. So please, at this time, submit your questions. Okay, so what we'll do is start off with our first question here from Craig. Craig asks, realizing it varies by individual being helped, how long does forensic peer support continue? For instance, a year, 3 years, lifetime?
I mean, I think that, Craig, you raised a very important question, and particularly in terms of, for a service industry, how much resources should we sort of put into an individual? And so, I mean, I would say that this work is ongoing, right? So it could be a lifetime, but it doesn't necessarily mean that it has to be that the forensic peer support is the person that's providing that services. In fact, we don't want to set it up that they're also becoming dependent on us, because we're then falling into this whole fostering dependence instead of creating community support. So part of the role of the forensic peer supporter is to work with the individual around connecting and networking so that they're building their supports in the community and have that as their go-to and not the individual peer supporter. That's really key, because we've seen that in our work, even in our work on the Citizenship project. Because folks are with us for about 6 months and they leave, and we find that, things work really well. And then within a month or two, we hear, a couple people might wind up back in jail or, just having other challenges. And so one thing that we've developed as a result of that is that we're providing post-peer support after they leave the group, so they can still touch base with the forensic peer supporter, but again, with the intention throughout of the involvement from day one to really focus on, what is the person's circle of support? What are the supports available to them, helping them to identify, what does support mean? And, what are good supports? And, who are the people that sort of just are there but may not be supportive? And also branching out. And this is hard work, though. That's why it has to start right away.
Thank you for your response. Do any of the other presenters want to respond to that question?
I just would add and agree with Dr. Bellamy in the learning from the Citizenship Project, for example, that you have what is a fairly intensive intervention, but only really two classes, 2 meetings a week, and then occasionally with the peer supporter outside of that, the need for some continued support. And we're talking about people who are often recently coming out of prison, who have been in very structured environments and have had very little opportunity to assert their own independence or interdependence, and are coming into a very difficult situation where they have a criminal record, which makes it difficult to find housing. It makes it difficult to find a job. And they have a mental illness and stigma and discrimination that's associated with that. So if you think about the kinds of supports that people may need, not only from forensic peer specialists, but from case managers and clinicians, I don't think that we're necessarily talking about more support just added on to that. It's a different kind of support. It's related to other support, but it's that knowledge of having been there, having been in that situation, of speaking from experience that seems to be part of what helps people move along.
And that it's more, we kind of go on that model of teaching them how to fish, that, that because that that you're not, that nothing's guaranteed for life, so that, we try to connect and get you out there so that, once that we've moved on, that you'll have other resources to go to. But I think because of the peer relationship, that the communication lines is always open, so it could be a lifetime, because it's a relationship, an intentional relationship trying to be built.
Okay, thank you for your question, Craig. We have another question. This is from Hector. What can we do to assist in the integration of this treatment option into new models of healthcare in this new time of healthcare reform at both the county and state level? Good question.
Well, I'll say a couple of things. I've been watching this like everybody else and trying to figure out what's going to happen and how it's going to work. And as you know, we have health navigators now, healthcare navigators. And I think that's really an area where peers and forensic peers can really be helpful. And I'm not sure that there's enough attention has been given to that. But it's that whole area of how you help people negotiate the healthcare system, and during a difficult rollout, and even then, how you gain access to healthcare services and support that go with those services. So I think in that there's probably no one better suited to that sort of work, particularly working with other peers, people with mental illnesses, people with criminal justice history. So I would say that would be one area where peers and people doing forensic peer work could really contribute.
Thank you, and thank you, Hector, for your question. Another question from Boo. What are appropriate levels of disclosure among peers? How to create boundaries between peer support and those in reentry process?
Well, I don't think that we the help boundaries and stuff, we try to build a mutual relationship. We don't really look at too much about boundaries and stuff like that. It's we're trying to work at supporting, not even helping, supporting people to get to the next level of where they need to be at, and that's wherever it is that they need to be, all while trying to make sure that we take care of oneself too. So I wouldn't say that I hope we focus too much about boundaries and things like that. We're just trying to build a healthy relationship and to support people, and while we take care of ourselves too.
And this is Chyrell. I just want to add that, you know, one of the things that we like about the work and of intentional peer support is that really from the beginning, talking about this relationship as being intentional. So, you know, understanding what the expectations are from each individual as you're entering this relationship. So in terms of boundaries, we actually use the term, you know, limitations or setting limits rather than boundaries, just because it sounds so fixed. Mm-hmm. But I think that's important in terms of, you know, for instance, you know, if you, particularly for peers, because, you know, sometimes we do just want to get. And, you know, so if you know, for instance, that at 5 o'clock that you're going to be eating dinner with your family, you know, really being able to say to the individual, listen, you can leave a voice message on my machine, but, and I may get back to you or not. But however, this is the time that I'm going to be spending with my family. And I think that's really good for an individual to hear, because it's role modeling essentially how to take care of yourself and how to take time for yourself. And that's one way of doing that. In terms of appropriate ways of disclosure, you know, a lot of the peer trainings, and definitely within the forensic peer training, we focus a lot on empathy as well as self-awareness, and really having a sense of, you know, who you are, what your stories are, what buttons, what are particular buttons that you have that might be pushed, and talking with an individual, and then using your story in a way that inspires hope and not, you know, sharing war stories just for the sake of sensationalizing the experience. But using the story in a way that's going to move, you know, the individual towards what it is that their goal is. We also talk about, Kim and I, this you know, if I'm talking, you know, this whole, you know, 80-20, or, you know, if I'm talking in a conversation with the peer person in recovery that I'm working with, and I'm doing most of the talking, then that's problematic right there, because they should be the one sharing with me. It shouldn't be about me sharing my story with this individual, monopolizing the entire conversation. And I think that new peers do need a lot of work around, you know, storytelling and knowing how to use your story. And I think that's ongoing. I think that, you know, for anyone who's using their story in their work, whether they're peers or not, knowing how to craft that and use that effectively takes time and attention, and it's something that will be developed over time.
Wonderful. Thank you, Boo, for your question. I hope I'm pronouncing your name right. A really good question. Appreciate the insightfulness of your responses, Kimberly and Dr. Bellamy. We have a question from Melanie. Who does the classes, a peer or a counselor or a team approach?
Okay, so you're talking about the citizenship classes. It happens in different ways. The Citizenship Project has a director, and there are peer mentors, and so sometimes the peer mentors will lead a class. Occasionally students will lead classes if they have a particular expertise or a particular interest. Part of the idea with the classes is you saw with some of the topics, from vocational issues to housing issues to criminal justice issues to mental health issues, is to bring in experts from outside. Why? Well, really two reasons. One is they're coming in at particular expertise so they can talk knowledgeably on that topic. Having someone, let's say, a realtor or housing agent come in and talk about how that works and about putting in applications for housing or for employment. The other part of it has to do with making connections with people in the community, building those relationships, making contact with those individuals, maybe following up with that person. From the perspective of the community person who's coming in or the person from the agency, they are learning as well as they're teaching the citizenship students. They're learning who these folk are. They're learning that they ask good questions. They're learning that they really are interested in gaining access to these services. That they ask good questions. So there's a process of education and, in a sense, community building going on there. So there's a lot of different things that are happening at the same time.
And I think that's really important because, as Dr. Rowe talked about in terms of the whole rights of passage, that rights of passage involves both the individual as well as the community. And this just like it's not just about the community, welcoming the individual, but it's also about the individual seeing that the community it's about the community learning about the individual, and through the classes, that's one way of them understanding them in a different way.
Did we lose?
Hello?
Hello?
Thank you for your answer. This next question is from Shiv Vargas. Can a mental health peer support specialist who does not have a history of incarceration but who has substance abuse challenges, etc., can that person still work well with a forensic peer student?
I mean, we certainly believe so. I think there are experiences that are quite similar in terms of that individuals who have experiences of being marginalized for various different reasons that can sort of fit in that similar experience, shared experience category. I think often individuals who have a history of substance abuse just haven't gotten into jail yet. Some of us just have been saved from getting into jail. So we certainly have family members and friends who have had those experiences. So we can, add that lens to it. But it does in situations where possible, particularly in organizations, and even with us, because of hiring issues, we've had to do that ourselves, hire some individuals who may not have had experiences with incarceration or had them a long time ago when the system was very different. So yes, we do believe that, that individuals have just mental health and co-occurring experiences can provide forensic peer support services. One of the things I would note, though, is particularly around the area of self-awareness and empathy, I think it's really important to stress that we understand some of the things that might get in the way and really check ourselves around some of our own, we're all influenced by society and have these sort of externalized, societal stigmas that about individuals with incarceration. So doing our best to not fall prey to, further stigmatizing the individual already. And I think that takes some work for individuals who may not have had those experiences themselves.
So
similar to what Dr. Rowe talked about in terms of the individual who just had the mental health experiences and needing to learn about empathy in terms of understanding about substance abuse. And it goes the other way too, when you hire individuals who just have a history of substance abuse, understanding that it's not as simple as me being able to, if I have a history of, if I have depression, that I can just get out of bed and, you know, everything is going to be okay. So I think there's a lot of learning and education that has to be done.
Great. Thank you again for that. And I know it's kind of hard because I'm reading the questions. You really can't interact directly with participants, but I just want to let you know Shivargis was courteous enough to say thank you to the presenters, and thank you, Shivargis, for your question. What we'd like to do right now is walk you through those questions again. This is our post-test section, so I'm going to turn that over to Chyrell to walk us through that.
Thank you. All right, we're going to go through the same 5 questions again, and then we're going to review the results. So at this time, question number 1 states, rights, responsibilities, roles, resources, and relationships are the 5 R's of citizenship. Is that true or false? All right, here are the results from that question. 100% of you all said true, and that is correct. The answer is true. All right, moving on to our second question. Cultivating intentional peer support consists of which of the following? Connection versus disconnection, worldview versus contextual factors, mutuality, moving towards recovery, or all the above? All right. Well, at 96% of you all said all the above. 4% stated moving towards recovery. The answer is all the above. All right, question number 3. Which are organizational benefits of forensic peer support? Is it improved outcomes based on connections, reduced recidivism, influences agency, culture, and overall recovery orientation, establishes known talent for career development, or all the above? Please submit your answers. All right, 100% of you, 100% came in with all the above, and that is correct. Moving on to our last question. Role clarity and salary equity is a challenge faced by forensic peer support and peers in behavioral health workforce. True or false? All right, 3% came in as false and 97% of you all came in as true. The answer is true. Okay, well, thank you for joining us for this post test. I am now going to turn it back over to Dr. Karen Kurosaki. Thank you.
All right, thank you all of you for participating in that post test. And once again, thank you to our presenters for your really informative presentation. I really appreciate how you've gone about this work to really develop a program and articulate the guidelines that make this, you know, a professional role for the folks involved. Thank all of you for submitting your questions and participating with us. Just one last little reminder that if anybody would like to receive continuing education credits, and you haven't already sent us your request, do so at this time. So once again, thank you, Dr. Michael Rowe, Dr. Chyrell Bellamy, and Ms. Kimberly Guy. Thank you very much. Thank all of you in the audience for attending. Once again, I wanted to encourage you to take a few moments to share your feedback as you exit this session. And with that, I believe we will conclude our broadcast, and thank you again for joining us.